for the refresher course in palliative medicine. Today we have three cases which will be presented by Dr. Hari Mohan, Dr. Nilima and Dr. Gitika, and we have our faculty members also. So after each case presentation we can all have discussion. So I hope you all have had a good learning session all these past few weeks, and you all will participate. So we can start now.
Yes, Dr. Gauraiya. So I just have a suggestion, like if the case presentation presenters can make the case presentation for around 5 to 10 minutes, we can utilize the next 20 minutes for active discussion. So we can start with Dr. Harimon's presentation.
Yeah. Good evening, sir, and the rest of the faculty, and also everybody else in the meeting. Thank you. I would straight away go in for that. This is a case presentation on phantom pain. Now, the history is patient S, male, 32 years. He was actually referred to me from the orthopedic department. He was treated for chronic osteomyelitis of the right tibia. They had done a necrotic bone excision and a tense nail insertion, I think titanium something, September 2018. And during the procedure, they found a soft tissue swelling anterior surface of tibia, which was also removed. The histopathology came as synovial cell sarcoma. So naturally, they had to do an ebony amputation. The inguinal node biopsy was negative, so it was only localized. So naturally, they needed only an ebony amputation as a cure for the synovial sarcoma and the chronic osteomyelitis that was there. This was done on 31st October 2018. Now, after the amputation, the findings that was recorded in the file by the ortho, he came back with pain in the lost limb, which was continuous and disturbing. And from the history, I found it was not very severe. It was around 3 to 5 scoring. It was quite uncomfortable. It was radiating and it was at times burning. There was a numbing sensation in the absent toes, and the feeling of toes being intercrossed and locked, which he found it very difficult because he could not obviously unlock it. And he was very depressed due to a pain for which he found no reason. They had put him on tramadol and gabapentin, orthopedic surgeons initially. So at this juncture, they had sent this patient to me. Now, I started him on, initially, I continued with the tramadol, as well as I changed gabapentin to pregabalin, and I put him on oral steroids, but there wasn't any relief. I started him on a low dose of morphine of 5 mg 4-hourly 10 mg-HS. There was very good pain relief and he needed no breakthroughs. But I also explained the mirror therapy to the patient before he got discharged, because it was something so simple and easy. He could make a rectangular mirror, and I told him how he could stretch the normal leg and watch the reflection. And I found out from him that he had done this, and strangely, his pain never came back. Not probably even before the mirror therapy, it became better. There was one more case also similarly. It got relieved, but with the mirror therapy tried. Only 2 cases I had seen so far. I had explained this mirror therapy to the patient as a consolidation after the discharge. Can I have the next? Yeah. Now the common, this is actually more than a case. I wanted to talk about this strange pain, which has interested me a lot, the phantom limb pain. What happens is, of course, there's a lot of cramping, shooting, stabbing, and burning. It's a typical neuropathic pain that happens in a limb that is not there. Yes. Next slide, please. The concept of this phantom limb pain, or PLP, is a pain that's coming from a body part that's no longer there. Once they believed this post-amputation phenomenon was a psychological problem. Even in history, we find in Var from the 15th century, I think, and Paris had initially talked about it. Nelson had lost his arm, I presume. And then it really happened during the war, the First World War and the Second World War, when people started losing their limbs in once the the firearms came to be, and also diabetes, of course, it was another common cause for amputations. So once the doctors believed this was a purely psychological problem, and the name phantom, I mean, that also contributed a lot. But experts now recognize that these real sensations originate in the spinal cord and the brain. Next slide, please. Now, the phantom limb sensation is a more gamut of so many other things. Like it is almost doesn't correlate with the pain reports. Non-painful phantom sensations are of three types, like kinetic sensations. So there are movement, kinesthetic of the size, shape, and position, and the extroceptives, touch, pressure, temperature, itching, vibration, all these things in an absent limb. Next slide, please. So this dramatically describes what happens to a person with the amputated limb, where the limb is not there, but he gets all sort of tortures going on there. Next slide, please. Okay, ultimately, we find that there are two things happening if you want to boil it down. One is that which is happening at the spinal cord level, and the other one that is happening at the central, the peripheral and central. Now, even though the limb has been amputated, the neurons that in the brain which used to control the amputated limb, it still exists. And we call it as mirror neurons. It's confused now as it gets no more inputs from the lost limb. And mirror neurons has been found to be one reason for the PLPs. The other one is neuroplasticity. Whatever we say neurons are like, they're not rigid cells that never change. They keep mold to the situation and circumstance. They change, they reattach, they reconnect. It's called neuroplasticity. So neuroplasticity has been also found to be another reason for the phantom limb pain. Next slide, please. Okay, this is the same thing which I have written. Next slide, please. Okay, as I told you, there are two possible places. One, the relevant body map area in the brain and spinal cord. There are mirror neurons. This has been studied by mainly by the functional MRI studies. Like in the functional MRI, with any movements, in the body schema in the brain, that area will light up. So that is how we study. But strangely, when the patient is asked to move the phantom limb also, the same places light up. So PET as well as the functional MRI has contributed a lot to show the scientific evidence of that phantom limb pain is not a psychological thing. It's something that is happening in real time. Now, since there are no inputs from the absent limbs, with time it takes sensory inputs from nearby areas. So what happens is in the body schema represented in the gyrus, prefrontal gyrus. Now, for example, as you all know, how it is represented. If, for example, the cheek is near that of the limb which is lost, so touching the cheek can also cause sensation in the absent limb. So that also is one more contributing factor to know that things are happening in the neurons in the brain, the central cause for it. Next slide, please. So again, do all amputated patients get the phantom limb pain? They say no. There are two risk factors where people were likely to get it. One is if the patient has had a pre-existing pain and this was not treated properly, the brain preserves the memories. So that one method is to remove the pain even by interventional methods before the surgery. And another thing which I read was epidural medications are given, like NMDA antagonists, before the surgery itself and post-operative period also. So this also reduces it. And then the pain in the persisting part of the limb stump, etc., could be because of the end neurons forming stumpoma, etc. And in ladies, the female sex, the PLP is supposed to be more the incidence wise. Next slide, please. Of course, the treatment is a multidisciplinary approach, the pharmacological and non-pharmacological and the nerve block methods. Pharmacological, more or less, it is treated like a neuropathic pain. The tricyclic antidepressants are used, which probably act by the blocking of sodium as well as the certain amount of NMD antagonist action. Anticonvulsants, as we all know by the usual method with neuropathic pain is used. The lidocaine um, uh, and the NMDA antagonists like mementamine and ketamine. Of course, opioids, the opioid receptors are blocked. It helps, and blockers, beta blockers also help in the channel blocking. So pharmacological agents have been attempted. Of course, steroids also should be added in this. Then the non-pharmacological methods like TENS, I think we should be OT, occupational therapy, physiotherapy, acupuncture, biofeedback, SRIT, massage, ultrasound, ECT. To a certain extent, it helps. And finally, the blocks, the nerve block, the neurectomy, the stump revision, the rhizotomy, the cordotomy, the lobectomy, sympathectomy, spinal cord stimulation, and even brain stimulation has been attempted to reduce this. Next slide, please. And above all, Vilayanur Ramachandran, neuroscientist, found out in the 90s. He was the one who made a massive difference by creating a mirror box where he provides the brain with the visual stimulation. By creating the box, the visual imagery of a normal limb is superimposed in the mirror, and the patient watches this. And it's sort of cheating the brain to tell that the limb still exists. And regular movements of that normal limb seen as a reflection in the mirror does help in reducing the phantom limb sensations. So the reflection of the intact limb is optically superimposed on the location of the amputated limb, tricking the brain into thinking that the phantom limb is real. Next slide, please. Okay, in this, this is not only in the limbs like upper limb and lower limb. They say the upper limb is around 80%, lower limb is slightly lesser. This can happen even in a removal of a breast, or even in the removal of a nose because of trauma. Any organ can produce phantom limb pain, but mostly it is seen in amputees, and that's why the most research is done. So in this, we can see it's a box which is collapsible, and this is not only used for people with amputees. At present, we also use for people with CVAs, like they have a paralyzed limb, which is made to, the normal limb is made to superimpose on that, and movements of that helps in the rehabilitation of paralyzed limb also to a large extent. So the mirror box, the other one, the one which is used for the leg is more easier. It's just a straight mirror on which the normal leg is reflected. The client is then asked to move his or her normal limb. Daily use of the mirror for 30 minutes a day is quite beneficial. Next slide, please. Yeah, this is the one I was talking about. For his left leg is amputated actually, but the reflection is seen of the right leg, and the movement with the right leg for a few days helps. Now, some people, it does not help also. They say it also depends upon how much the person believes in this. His attitude also, to a certain extent, it is subjective also. Next slide, please. So it is a syndrome in which the patient experiences a sensation that the limb is still present. These patients can also feel pain and cramping in the missing limbs. It's because of the mirror neurons and its neuroplasticity that these things happen. Now, something which is very interesting is since the 90s, we have moved forward to something called virtual reality. The virtual reality is now seriously replacing even the mirror. Of course, the cost is enormous. this is called as something called as serious gaming, because mostly the virtual reality is used in gaming, but here it can be medically used also, because in virtual reality, the absent limb is made to be there in the mind of the patient, and he's able to walk or run or anything. And so this does help the patient in a large way. But of course, the technology has to bring down the cost before it is being widely used. The mirror box is so simple and so effective and cheap also. So this is the serious gaming part of it. Quite interesting things are happening in this. The next slide, please. Yeah, thank you so much.
Thank you, Dr. Hari Mohan. I think this is a very good case presentation, and also the explanation which followed has enlightened us on the details of phantom limb and its causes and the possible treatment options which are available. So I invite our faculty to give their inputs, and also if anyone of the participants would like to ask any questions or discuss anything which they feel they want to talk about, you can do so.
I think Dr. Manisha is putting some answers in the chat. Let her talk about her experiences. Dr. Manisha?
Yes, good evening, sir. Can you hear me?
Yes.
Yes, sir.
Yes, actually, we had done a very good, we are doing mirror therapy in many patients, but I remember one patient particularly because it was a phantom limb pain. And we had tried almost all the treatment procedures which Dr. Hari Mohan has mentioned. And ultimately, the best result we got was with mirror therapy. So if you want, I can just give you a gist of the case. It was a young male patient of about 45, and he had his hand had gone into a machine. So he had an avulsion injury of the brachial plexus. And initially he went for surgery. There was an amputation. It was above elbow amputation. And after about 6 months or so, the patient started having a phantom limb pain. So all the procedures were tried. Then the patient was sent to our pain department. And we had initially given him medications. Then we tried nerve blocks. We tried IV lignocaine. We tried IV ketamine. Almost all of the procedures were done, and each procedure gave him some relief for some time, but he never got full relief of pain. And the patient had tried suicide also. He had attempted 2 to 3 times because he had lost his job. He obviously his social life, his psychological status, everything was suffering. And so then we heard about this mirror therapy. And at that time, I was doing my pain fellowship. So we had gone to an institute where mirror therapy was being tried on serious patients. So we learned mirror therapy from there. And we came and then we tried it on this patient. It was the first patient on whom we tried. And we got really very good result, because we used to mark the area where he used to feel the phantom limb pain. It was almost on the upper back, on the scapular region. We used to mark the area where he used to say, now you are scratching my thumb, now you are touching my finger, or he could not unclench his fist. He always felt that the phantom limb, the fist was clenched, and he could not sleep at night because of that. But with mirror therapy, gradually we convinced him, and he could unclench his fist first of all. Then he started having pain relief. And so that was one of the wonderful cases that we had of mirror therapy, because we had thought of spinal cord stimulation as a last resort for this patient. But since he was a laborer class patient, he could not afford the treatment. So that is what I wanted to share with you all, that mirror therapy does work. And then we have tried it in CRPS patients, in different types of pain management procedures, and we got good results. So,
thank you.
Thank you, sir.
Manish. Thank you, Dr. Harimohan.
Thank you, sir.
Very good sharing of experiences. One of the problems here in phantom limb pain is that in any institution, the numbers are small, and really good evidence with randomized control studies is not easy. In fact, we do not have any. Totally acceptable RCTs are not there. So everything is anecdotal. Manisha, I have a question to you. Your patient with phantom limb pain had good results. How long could you follow up the patient up?
Sir, when I had followed up the patient for about 6 to 8 months, but since I am still attached to the institute and the patient is very much attending follow-ups, so I think last 4 years we have.
That is fantastic. That's fantastic.
Yes, sir.
If anybody, when you talk about a chronic pain, remember something that I think, I don't remember whether it was Hari or Manisha who said it. With everything, almost everybody gets some relief for some time. But usually that kind of relief is limited to about an average of 3 weeks, maybe a bit more, bit less. So let us not decide on efficacy by short-term treatment. This is not about the 2 patients or 3 patients that you all talked about. I'm just generalizing. For the group here, someday or other you will come across a patient. You will not see one for 4 years and then one may appear. I think we need to remember a few things. One, there is evidence that if the analgesia prior to surgery is good, the chances of phantom limb pain are less. Or even if it occurs, it is less severe. One. Secondly, the management would be different between early and late presentation. If you are starting treatment within a period of 3 months, then the results are best. 3 to 6 months may be okay, but beyond that, you may not achieve total relief, but the nature of the pain can be made more acceptable and intensity may drop. If it is early, I would go for tricyclics as a first resort. And as Dr. Harimohan said, opioids may help, very variable. Do not be surprised if some people do not respond to opioids at all. Some people respond, others may not. Of the whole, okay, and later on, as Dr. Harimohan said, opioids may help. And if they help, we should start that. Remember, it's a chronic pain and they may need it for a long time. They must be clearly understood about the addiction potential. And they are not strictly, they will not be allowed to increase the dose themselves. There will be a contract between you and your patient not to escalate dose. Whatever is there will have to be continued. And if the dose required increases, that's a danger signal. About the results with pregabalin, there may be controversies. I'm not going into that, but we do know that in early situation, tricyclics help. Gabapentin or gabapentinoids may be helpful. I know that Shashi has raised hands. Just a minute more and mirror of the whole lot of things that are available. Mirror therapy seems to be the most consistent. Unfortunately, unlike in many other pains, NMD antagonists do not appear to give excellent results. Again, this is unpredictable. An occasional patient may benefit. So sometime back we had done a Sunil, did we have a session on difficult pain for this group?
No, sir.
Huh?
No.
But during your yearly training, you may have had sessions on difficult pain. So many other things would be applicable, like checking for adherence to treatment. Lignocaine intravenously doesn't seem to help in the vast majority of patients. Ketamine is to be given a trial, but limited purpose. Opioid trial is good. Amitriptyline gradually stepped up, still carries a good chance, even if delayed. And of the whole lot, to repeat, mirror therapy seems to be to give the most consistent results. Shashi, you wanted to say something?
Yes. We had a patient who had amputation for below elbow. In that case, immediately after the amputation, we gave brachial plexus for 3 or 4 times. Then he had good relief. Along with that, he was given other drugs also. I don't know whether it is because of this brachial plexus block or not. The patient was referred from orthopedics, and later they went for prosthesis, etc. After
Shashi,
brachial plexus block.
Shashi, what I would suggest is, if the preoperative pain is well treated, if the postoperative pain is well treated, the chance of phantom limb pain becoming severe is less. That is well known. And as you, I think it was good strategy, because brachial plexus block can give the quality of pain relief that is difficult to achieve with analgesics. Total pain relief. That will be, it stands to reason that it could have helped, but I repeat, any analgesia, adequate analgesia, preoperative and postoperative, is vitally important. Thank you, Shashi. I think by Gauraiya's calculation, we can have 2 or 4 minutes more for this person, this issue.
Yeah. Dr. Nivedya has put in the chat box. She's asking, Shashi sir, what did you give in the brachial plexus block?
Repeated boss with the bupivacaine, 0.25%.
Sir, I was reading a systematic review on mirror therapy, and it says there is no evidence for mirror therapy.
This is problem, Sunil. For something like phantom limb pain, nothing has good level of evidence. Just because good RCTs are not easy to do. Both, in the article that you read, Sunil, did you find good evidence for any form of treatment?
No.
No. So it's only relative. Not one thing has good evidence to support it. But then that's the case for many rare conditions. You cannot have enough numbers to generate good evidence.
Sir, one question, sir.
Yes, Manisha.
Yes, sir, when I the period when I was talking about this patient, I was in pain management, so I didn't know much about palliative care then. But as the patient was very close to us, so we had tried all sorts of psychological counseling and everything for the patient. But now I would like to ask you that since there is no definitive treatment for phantom limb pain, as palliative care physician, what do we do for such patients?
So, Manisha, I'm glad you asked that question. So most importantly, we never abandon the patient. This patient, as Manisha pointed out, needs us, even if we are unable to give excellent pain relief. But I might have sounded very pessimistic because of the evidence. Poor evidence doesn't mean inefficacy. It just means that good research is not possible in that group. That's all it means. So let us not assume that nothing works. It just means that there is no good evidence. So as we said, all the modalities of treatment that we mentioned, we will try. But arising from Manisha's point, I'll mention 2 things. One is that we will use opioids in spite of the danger that this will be a very long-term affair, and there may be even at least 4% chance of development of addiction. That's a possibility, which is why I mentioned some conditions. That's one thing. The second thing is, as a palliative care physician, what Manisha will do is not to abandon the patient, even if pain relief is partial. Usually, zero relief from pain is unusual. It can happen. Majority of patients will get some pain relief. And then we will have to talk it over and say that if there's any worsening, you must come back to us. And maybe you will come, say, once in a month to see what else we can do. But you will, one thing that is to avoid is not to try desperate invasive measures. Just because we are desperate, we will not try say things like, I mean, Manisha, I am glad he could not afford that intrathecal electrode implantation or something like that.
I'm also glad, sir, because I do not, there
Can I
is no
just-
evidence for that too.
There is a question about methadone. Possibly, I don't think we'll find a lot of evidence in favor or against it. Generally about methadone, Sunil has more experience with it. After all, it's a neuropathic pain. Maybe methadone will be more suitable than morphine, but I really do not know. Sunil, you looked up the systematic review. Did you find anything about it?
No, I don't know that about it, sir. We have not tried with methadone as we didn't get a chance.
Okay.
So can I just put in a few words about the patient whom I had seen?
Hari, just try to finish in 2 minutes because we have exceeded that lot of time.
Both of them I had followed for more than 4 to 5 years now. I've been keeping in touch and calling them up. It was a conclusion. They had no more pain. I don't know whether it was because of the morphine or because of the mirror, which they did try, but they had no pain and they did have the panther pain earlier. There was no doubt about it. They did have a thing in both the cases. And yes. I feel the number of cases of amputees are quite a lot. And the number of people with PLP is also quite a lot. I really don't know why there are not much of RCTs. Probably it will come in the future. And I'm sure this mirror box is definitely useful as far as we are concerned, because it's going to be cheap and it's not going to cost in any way. So even if there are not enough RCTs, that's something which we can think in terms of other complex pains also, strokes and other things. Maybe we can, among ourselves, it is not restricted to the amputation pain alone. It's not restricted to the phantom pain alone. It is related to the complex pains also. We should also think in terms of starting such trials and then getting some results out of it.
Thank you, Hari. Shashi has raised his hand again. Considering the time, Shashi, please make it brief.
No, sir, I have.
Okay. Thank you.
Now,
Gauraiya, back to you.
Yes, we can proceed to our next case presentation now. Over to you, Dr. Gitika.
Good evening, sir. Good evening to the faculty present and all my colleagues. May we go on to the next slide, please. So, sir, there's a small information. I happened to see this patient in my very initial learning of palliative care. And there was, I got to see the patient only after she was terminal, she was bedbound. And most of the information that I have charted here has come from her husband and some documents which they had furnished. And since I'm a newcomer, I would request all my faculty to please guide me with all my mistakes so that I can learn more. Thank you. So there's a 25-year-old patient, a female patient, who was diagnosed with inflammatory carcinoma of the left breast. So the diagnosis was invasive ductal carcinoma grade 2 stage 4 with multiple bone metastasis. Her presenting complaints were that she was having severe pain in the left breast region, which was radiating to the back and also towards the neck region. According to her, the medication which was being given, it was not relieving her pain. It was too distressing. And on examining, I found a big fungating wound on the left breast, which was almost involving the complete left breast region. There was a continuous foul swelling discharge from the wound, and she was also experiencing loss of appetite and sudden weight loss. She was getting fatigued even while performing routine activities like cooking for her children. Sorry, I lost track. So the history of the illness was this 25-year-old female patient experienced a lump which was becoming increasingly painful with time. And this happened during the third trimester, around the 8th month of her second pregnancy. She was having a daughter who was about 3.5 years old. She went to a close local government hospital to get herself examined. And the doctor there assumed it to be an abscess, considering her age and her general condition. And they did not decide on conducting any further examinations, but straight away they decided to give an incision to drain it, considering that it was an abscess. Once the incision was given, the incision site never healed, even after months. The nick transformed into a wound and then a big fungating mass. The size of the lesion rapidly increased. Her pain was becoming increasingly unbearable. There was a very limited knowledge of things that were going on with her, and her husband was a daily wage earner, so they did not want to complicate the final term of her pregnancy, so they decided to go to a higher center in a nearby township. After a series of investigation, the husband was informed that it's a malignancy, but the patient was still not informed about it. So all definitive treatment was withheld in view of the approaching childbirth, but this only kept on piling up with the agony and the distress and the pain. After the birth of her second daughter, after about 1 month of the birth of her second daughter, she was put on chemotherapy, radiation therapy, because surgery had been ruled out due to a progressive disease. Next slide, please. It was clinically identified as a highly progressive disease. The poor prognosis was explained to the husband. The patient was still not completely informed about the disease. She was in second-line chemotherapy. She was referred for palliative radiation to the pelvis because of the metastasis. There was a continuous ooze from the left breast, from the wound over the breast. So a radiotherapy, hemostatic radiotherapy was also considered. All this happened within less than a month of the birth of her second daughter, which was a cesarean section. So mentally and physically both, it was a very difficult period for her because she had barely recovered from the postpartum distress and she was already going through so much. She was experiencing a very severe pain in the left breast. There was this big unhealing wound. There was a lot of foul smell. There was a continuous discharge. The pain was radiating to her back, neck, and her shoulder. All her movement gradually and her eating, the activities of daily living, they all ceased and she was completely bedbound. Within no time, unfortunately, because of the weather conditions and the care she was getting, she developed pressure sores on her back. Still, she was unaware of the diagnosis and she was completely distressed about everything that was happening around her. Next slide, please. So these are the basic things that we examined. Her investigations were more or less fine. These are the two comparative investigations which were done about at a month's difference. ECOG scale was 1. There was no pallor icterus cyanosis clubbing edema, but her left breast, there was a 20 by 20 centimeter lump which was occupying the complete left breast. And there was this diffuse erythema and tenderness with a 3 by 3 centimeter ulcer, which was present just below the left nipple, and there was a pus discharge. The nipple was everted. Her left axilla had a 5 by 4 centimeter tender, mobile, firm lymph node. The right axilla had a non-tender 3 by 3 centimeter firm lymph node. The left neck region had a 5 by 4 centimeter lymph node, which was involving level 3 cervical and supraclavicular. It was tender, firm, and mobile. Right neck, there was no abnormality detected. Next slide, please. So the patient was given a tablet cabergoline 1 mg by the gynecologist after the childbirth for milk suppression because that was adding to the problem. She was given 3 cycles of palliative chemotherapy within about 1.5 months, which I was told. After explaining her husband all the details about the current status of the disease and the treatment options that were available, she received packed RBCs because of low hemoglobin before the chemotherapy. Subsequently, she was put on supportive care and second-line chemotherapy with paclitaxel and cisplatin. She received radiotherapy to the pelvis and pelvis and bilateral femur, and hemostatic radiotherapy to the left breast. Several cycles of radiation therapy and chemotherapy were repeated unless she was severely neutropenic, anemic, very weak, and she could not take it further. And hence, she was refused any further therapy by the hospital. So as for the medications, I think she was on a lot of medications right from the beginning. By the time I saw her, she was taking ondansetron, pantoprazole, she was taking multivitamin, paracetamol, Shelcal, vitamin D3, Rantec, MCET, everything. And when I saw her, the main The main medication that she was taking was paracetamol 650 mg TDS, tramadol TDS 50 mg, and gabapentin she was taking 300 mg TDS. Apart from that, for the ooze that was there, Trenexa was given. And apart from all those medications, daily wound dressing was being done with crushed metrogyl tablets. It was being washed with metrogyl solution. The only problem here was that she did not get adequate nursing care, and the dressings were being done by the husband. Whenever he used to remove the dressing, there was some desquamated tissue that used to stick to the dressing, and he used to pull it out and it used to start bleeding. So that increased the fear of both of them for the dressing. And the husband used to shy away from changing the dressing every day, telling her that we would do it the alternate days. Whereas she had this feeling that she should be dressed every day because that made her feel a little better. The continuous foul smell was very distressing. The ooze from the wound was so bad that she used to wet all her clothes within hours of dressing. And towards the end, she also had terminal delirium. She was on lorazepam and tablet haloperidol was also given. Next slide, please. So there were a lot of psychosocial aspects that were involved. First, her distress increased many-fold because of the psychological factors that their marriage was against the wishes of both the families, and she felt that there was no support from either families, from whichever side, because of this reason. And again, she felt because she did not listen to her parents, this was one of the punishments that she was receiving. The husband was the sole caregiver and the breadwinner. He was on an ad hoc basis. He was a peon and he was managing work. He was looking after both the children, a newborn and a 3.5-year-old daughter. He was managing the household. He was dressing and taking care of the wife. And it was becoming increasingly challenging for him physically, mentally, as well as emotionally, because he was also 27 years old. So as the conditions worsened, the patient became very critical and she even became short-tempered. She used to be very critical and annoyed, angry most of the time with her husband. And the wound, maybe that was a coping mechanism which she was developing. And the wound condition was extremely bad. The foul smell and the starch made it worse. Managing the dressings was becoming scary, as I told you, because of the bleeding. And the reluctance to change dressings worsened the wound and the condition further. Next slide, please. She was completely shattered and lost the will to fight the day when one day her 3.5-year-old, she called her 3.5-year-old daughter to her and she refused to go to her, saying that there was a very foul smell from her mother, and she did not want to be close to her. So that was the day when she admitted that she did not want to live. And her not being able to breastfeed her newborn was another thing that was taking a big toll on her emotionally, because she was very upset by the fact that she could not mother her like we normally consider. She was having many complaints from everyone around her, be it her family, be it her husband. And she was mostly angry whenever she used to talk, or she used to be quiet. She did not feel like responding. Force feeding was adding to her distress because since there was no caretaker, we tried to convince their neighbors to help them out with the household chores, because it was becoming increasingly difficult for the husband. But then because of the ignorance, they tried to feed her, just caring for her, which was becoming troublesome for her. She was devastated by the amount of nursing care that she was requiring from her husband. He had to change her diapers. At times, the linen was soiled, so he had to change it and wash it. Belonging to a hill station, it became increasingly difficult because they had to be washed and dried. So she was very ashamed, and the foul smell from her wound was a big blow to her dignity in every which way, because that was one thing that was making her very sad and depressed. The strong stink also added to her nausea, and she said that she did not feel like eating anything because she used to be in that smell 24/7. So it made her feel very nauseous and did not want to have anything. And she said that it was better to die than bear the smell all the time. Her husband also reported that she tried to commit suicide by, the only thing she could do was hold her breath. So she used to hold her breath and try to suffocate herself by her pillow, her own pillow, but did not happen. They tried to check her, but she was very devastated. She was worried about her daughters, and the only thing she used to ask from her husband was that she needed a commitment that he will take care of the daughters after she was gone. She used to miss meeting her family towards the end because they were not in talking terms with her. So we did try to make an arrangement. We spoke to her father because her mother was no more, and we got her father and sister to come pay a visit to her and meet her, stay with her, and spend some time close to her last days. And COVID made the situation worse in every way because every time they used to go for medical help, they had to take those 2 kids along, and no medical help was available to them at a distance shorter than 6 to 7 hours. So everything was becoming difficult day by day. Next slide, please. So her main concerns was her children, first and foremost. Her husband was also very young, and she was taking care, and she knew that it will be very difficult for him to take care of both the daughters alone. So, and she mentioned the concern that her husband's family might consider getting him remarried, and then who would take care, who would stand for her kids. She was not included in any major treatment discussions. She did not know the diagnosis. Every time she used to ask, she was being turned down, and accidentally they went to an Ayurvedic doctor after all the treatment was refused, and he very abruptly in a very rude manner told her that you have cancer and you'll not survive for very long, it cannot be treated. So the way it was disclosed to her was very shattering, and it made her extremely upset with her husband also, because she was upset that he did not tell this to her earlier. After the husband was explained the prognosis and the futility, he did not want to take her for the treatment, and they started fighting over the issue because she thought that he's not taking her purposely for some reason, and she did not know the complete picture. So she was becoming very restless. The center where she was undergoing treatment was way too far, and going there was expensive and difficult. Wound management at home was becoming increasingly difficult despite trying. We did try helping them out with newspaper dressings for absorption. We did try dressing it with diapers. We did suggest them mopping the floors with lemongrass oil, and we used to tell them keeping a bowl full of lemongrass oil in the room, and certain small things which could help them with the sting of the wound. Pain management was
Geetika,
yes, sir. Yes, sir.
if we are to have any time for discussion,
Yes, sir.
maybe you will try to
I'll
summarize
quickly
and
wind it up.
close.
Yes, sir. Yes, sir. I'll do that, sir. So managing her terminal delirium was difficult because the husband was being distressed and spiritual distress was not handled. Next slide, please. So, sir, instead of going with the summary, sir, I just want to highlight 2 things. We did try getting a counseling session arranged online for the husband and for the wife separately. We tried talking for the adoption, which was refused by the family later. And so we did try and arrange some respite care for the husband. But next slide, please. But I think that the case could have been managed better in terms of psychological and pain management. Apart from that, sir, what could have been done to decrease her agony as a 25-year-old new mother who knew that she had to part with such 2 young kids? And so nursing care also was deficient. I think I addressed it here because discussion is more important. So I think we proceed. Thank you, sir.
Geetika, what a sad story. It is a sad story, but you tried your best. The suffering was caused by that cruel cancer, but also possibly caused by the way she was treated, including the lack of information, including not concentrating on quality of life with the time that she had. So, and that was very sad. So, Sunil, Gauraiya, would you like to proceed with the discussion? Anybody wants to make
Thank you, sir, and thank you, Dr. Gitika. This is indeed like I was lost listening to the story, but I feel I've seen many cases where there is very foul smelling wounds. So Metrogel dressing help with smell actually. So and did you try that?
Ma'am, we were doing it for about 2 months continuously, but it was going from bad to worse. It was, ma'am, you can't believe that when I used to go up pay her a visit, and I used to stand in the room, the stench was so bad that it was difficult for me after wearing 2 masks to stand there for 5 minutes. It was that bad. So I could understand the distress that she was facing because of it. Ma'am, we did try charcoal dressings also, but then it did help, but to a certain extent. We gave her systemic antibiotics also, but again, that also helped to a limited extent.
Just
yeah.
one word, sir. Local pain in the wound can be suppressed by applying powdered morphine along with the dressing also.
Well, powdered like morphine, maybe injectable diluted is better because morphine is not soluble, but also local anesthetic, provided the wound is raw. If there is a lot of slough and dead tissue, that may not work. Yes, many questions. For majority of questions, the answers are obvious. I was putting myself in the place of a patient who is not told, no information was given. She maybe would have died. I mean, I'm sure she would have died anyway from the illness. But if it was possible to have some time focused on quality of life, maybe things would have been better. I don't know why the control of the foul smell was so difficult. Possibly because neither the Metrogyl nor any medicine you were giving was reaching the cells, because maybe it was all being applied only on the dead tissue and it was not able to get it controlled. In such a case, maybe a toilet mastectomy would have been the only thing that would have given some relief. But then we would have they still regretted doing it because that wound may not have healed. Vidya, I am glad that she had a very considerate and caring doctor like you to care for her. I am feeling distress thinking about the woman's distress and the husband's distress. That man went through such a lot, and being blamed by both families, having to look after the babies. Oh, what a horror. You said lack of nursing help complicated things further. Any social support that was available could have only gone towards supporting that family more, because I can understand that man's difficulty in continuing the dressing, because it would have been so very difficult for him. You were available, Geetika. Available palliative care physician could have helped to manage things better.
I did go to they could go to their place for the dressings, but since they were slightly far off from my place, I could not go there every day.
Yeah, I understand.
I used to help them. Sir, the wound was huge, sir. I wanted to share the photographs, but I asked the husband and he was not very convinced and happy, so I did not do that. Sir, as for the husband, I tried to arrange a counseling session for him. So that day he broke down and he said that I'll be happier if she goes, if she passes away now, because I can't bear it anymore. And sir, sir, as for the sir, I'm still in touch with him. I try to take care of the two daughters who are there with him, and I try to, sir, and the small thing that we could arrange was that it was Diwali just before she passed away. So just for a legacy for her children, I went there and clicked several photographs with the family. And there is something very traditional in a Hindu culture, is a Mangal Sutra which they tie in their neck for a married female. So she wanted to have that, so we took that for her. And she was happy, sir. I still have those photographs and I feel very nice when I look at them, but I still feel there could have been much more which I could have done for her, which I failed to do. So I feel bad about it. Very sad, rather.
In that sad story, Sunil, I was thinking of our patient with lymphedema at the beginning of the first lockdown. I have forgotten her name, a very unusual name. Similarly, I mean, I know how much all of you, everybody in our team suffered when that woman was there. But thinking about your patient, Geetika, and thinking about some of the most difficult patients that we have had, amidst all this sadness, I have a feeling that you did everything. And that is not a small feeling. For that man, you would have been the only island of hope. If we are to take any lesson from this woman's story? One, that even when you think nothing can be done, even when there is suffering is agony, it is so important for you to be giving your time and whatever you can to the person, because many of these people have nobody else. Most people run away because they can't take the suffering. The other message I would say is, maybe all of us have such a lot to do to improve awareness, to improve teaching and learning and communication. Because if I will not blame any of the doctors, because if they had gone through enough training, they would have learned the importance of communicating bad news. They would have learned how to try to communicate the bad news and try to help the woman and the husband to live with the problem as well as possible. I think you know the answer to the other questions. Did collusion complicate it overall? Of course it did. Knowing that the end was certain and approaching, what better could have been done for 25-year-old? Withdrawing needless treatment, and which would only add to suffering. When you said availability of palliative care professional, what possibly, that's a fourth bullet point in the second column. What we possibly when was right there at home, and this would have been practically impossible. Even in a hospice, there would have been restrictions. Maybe many things more could have been done if we were in another country and if our facilities were more. But before we conclude on that, this particular patient's story and Geetika's remarkable journey with the patient and the husband, does anybody have any comments or additional answers to any other questions?
I want
Just want to get a group's opinion. The Ayurvedic doctor, as per Geetika, he broke the news very abruptly, and but I don't know whether that was a good thing, even though it was broken abruptly, because otherwise she would not have known it anyway. And so, what do you all think about this? The communication of bad news in an abrupt manner may not have happened, but that was she knew the news because she met and saw that doctor.
To me, I feel most of our patients, unlike the collusion standards we have in the West, I mean, of course, we should explain to them when we are around. If we are not around, as Sir told, many of them, the other medical professionals are not aware of this, or the abrupt way, as you mentioned. Most of the patients, when they go through this radiotherapy and chemotherapy, which they link with cancer, they get an idea of what they're having, which is a wrong way of knowing it, of course. It's not that they're totally ignorant. I'm sure this lady knew what she was having and she was going to have a futile end also. But of course, she should have been explained. There's no doubt about it, in a nice way, definitely not in an abrupt way. But happens in most patients, even when there is a lot of pollution among the family and other people trying to hide. We find the patient, when we really question them, he is aware of a lot of things, maybe wrong. We should correct it and put it in a correct perspective, but they do know things.
So you're very right. This disclosure, I think she partly knew that there was something wrong, but this disclosure came as a shock. Maybe the way that it was told to her, and it only increased her anger, her agitation. She knew that there was something wrong. Every time I used to go to her, she used to ask me, will I get okay? Will I ever be able to get okay? Will I ever be able to take care of my kids? Will I be able to cook for them? So she knew that she was deteriorating. But maybe the way that it dawned upon her made her completely shattered.
Were you able to answer her question?
So most of the time I used to keep quiet. I wasn't, I mean, my learning was very new. And all I used to tell her was that when she asked me, will I be able to cook for my children? So I used to tell her that even if you're not able to cook, when your husband is cooking, you can sit with him. You can just be there for them so that they have you there and they feel your presence. That is very important. And the days when you feel better, you can ask them to help you with the cooking process. And when she told me that what will happen to me, I just kept quiet, sir. I just told her that we are doing our best to make you feel as comfortable as possible in these circumstances, and so that you don't have to run with your children. And if there is any problem, you can call me even in the middle of the night. I'll do the best that I can. So that is what I told her. I could not say anything else.
Geetika, so I think, sorry, who was speaking? Was it Sunil?
Yes, sir.
Go ahead,
So,
Sunil.
Geetika, what you did is right, but we are still kept her in an uncertainty without telling the news. So she must be anxious about what is happening. Nobody is telling me things correctly. So all those things might be going through her, but I think you did a good job. So thank you, Geetika.
Sir, one last question, sir. Just 1 minute, sir. So my first question, so was the attempt to the incision and drainage justified without any investigation?
One of the oncologists, will you please say? I mean, I have seen it happen again and again.
Sir, I was very
in our
upset
country.
with
Yeah,
this happening. This is the biggest regret I have throughout my life.
This is terrible, and it keeps happening. All of us have seen this happening again and again.
Sir, but what can we do to prevent this from happening to other people? Maybe she could have been in a slightly better position had this not been done.
See, there are many things that could have been done differently, including that IND should not have been done. Manu pointed out as an oncologist in the chat box that even in the last trimester, treatment need not have been withdrawn. We could have been more rational about the treatment. The doctors should have learned how to communicate bad news, but it's not their fault. It is not there in the curriculum. It has never been taught. It's quite understandable. The fact that he was an Ayurvedic doctor had nothing to do with it. Well, it's not the degree MBBS or MD that matters. Nobody is taught this. So here, that was wrong. A teleconsultation will be effective. Well, certainly better than nothing. That's all. Nothing like the person seeing your face, Geetika, establishing eye contact. The psychosocial agony, the best way could have been to for you to sit with her, find out what she knows already. What do you think it is? Do you really want to know? And giving truth in a little bit of increments. But without her husband's permission and awareness, it is practically difficult. So it would be important to talk to him also. So these are all things that could have been done differently. But what was to be admired is that you did not desert her, even in the very difficult situation. And because of that, Geetika, I hope when my time comes, I will have someone like you to care for me. Thank you very much, Geetika.
Thank you. Thank you so much, Dr. Geetika and Dr. Rajagopal, sir. And this case was very good and we had a good discussion. But now it's time for the next presentation by Dr. Nilima.
Good evening, everyone. I hope you can hear me.
Yes.
Yes. Good evening, sir. I'm a neuroanesthesiologist, and my case today is a neurological patient. This was a 68-year-old lady who came to us with a hypertensive bleed. Her diagnosis was a left-sided ganglio-capsular hemorrhage with a midline shift with intraventricular extension of the bleed. Next slide, please. She was found lying unconscious in the bathroom floor at her home one evening a couple of months ago, and she had no response to calls. There was no prior history suggestive of seizures. She was brought to the emergency department of our hospital for further evaluation. She was a hypertensive for 15 years on tab amlodipine once a day and also a diabetic on oral hypoglycemic agents. She was brought to the emergency department. In the hospital emergency department, she had a low GCS and therefore they intubated her. She was subsequently underwent a CT scan, and the CT scan showed a large hypertensive bleed. It was a large acute intraparenchymal hemorrhage in the left frontoinsular deep white matter and the left ganglocapsular region with a mass effect in the form of an effaced left cerebral cortical sulcal space and a subfalcine herniation to the right. Now, in the face of this large bleed, the bystanders were counseled on surgery versus medical management. So they were given the option of a decompressive craniectomy and clot evacuation as a life-saving measure rather than expecting any neurological improvement. And they were also explained about the pros and cons of medical management alone for this condition. Next slide, please. The bystanders opted for surgery. So she immediately underwent an emergency left-sided frontotemporal parietal decompressive craniectomy, clot evacuation, cisternostomy, and a lax uroplasty. Post-surgery, she was mechanically ventilated and sedated, and her other medications like the anti-edema and the anti-epileptic medications were continued. 24 hours after the surgery, she underwent a post-operative CT brain scan. This showed a significant reduction in the left frontal intraparenchymal hemorrhage with some patchy residual bleed, mainly in the inferior portion and posterior ganglocapsular region. So her sedation was stopped and she was reassessed. However, her GCS remained poor in spite of the continuing anti-edema and anti-epileptic measures. In the face of this, the family members were explained about the patient condition and the CT findings, and the poor prognosis was explained to the family members, and they wanted de-escalation of treatment. Next slide, please. So a multidisciplinary meeting was conducted with the surgeons, with the ICU team, and the family members. The course in hospital was discussed with them, and possible worsening of clinical status was also conveyed to the family. The family opted for palliative care in view of poor neurological status and a possible poor outcome. They did not want any further surgical intervention, and they wanted de-escalation of the inotropic supports that she was on. With this, her renal functions worsened gradually, and she became anuric. The patient's family was again explained about the high chances of further worsening of hemodynamics and cardiac arrest, and she subsequently had deterioration of her hemodynamics and subsequently had a cardiac arrest. Next slide, please. On examination, she was on a ventilator with a Glasgow Coma scale of E1, VT, and M1. She was moderately built and nourished, sluggishly reactive pupils. She was initially on inotropes, on anti-edema and anti-epileptic measures, but this was de-escalated on request of the son. Next slide, please. Treatment and significant investigations in view of the hypertensive bleed and the CT scan findings. A decompressive craniectomy was offered as a life-saving measure after explaining the risks and the possible post-operative prognosis. And the family opted for an emergency decompressive craniectomy. Now, the psychosocial aspects, both adult children lived abroad with their families. This was a couple of months ago at the height of COVID restrictions. So both the daughter and the son found it difficult to travel. The eldest son was the one who was able to come first. However, his family was not able to travel due to COVID restrictions. The daughter, who was a nurse in the UK, could come only a few days later. Since it was such a sudden event, they naturally found it very difficult to accept this very sudden traumatic event in their lives. And once they realized the prognosis was poor, they wanted to take her home on a portable ventilator so that they could spend more time with her. So while they were arranging for this, what we tried to do is we shifted her to a single room within the ICU so that the family members could stay by her side most of the time in her last moments. Next slide, please. Medications. Prior to this, she was a hypertensive on tab amlodipine, a diabetic on oral hypoglycemic agents. And while on the ventilator, she was on inotropes, anti-edema, and anti-epileptic measures. The inotropes were subsequently de-escalated at request of the family. Next slide, please. Now, the main concerns that we had, one is towards the end, she started gasping on the ventilator. And the daughter she had shifted her to a single room, and the daughter was with her most of the time. And this was a significant source of distress to the daughter, who was with her most of the time at that time. But the son, however, had expressly stated that he did not want any medication to be started. So we did not restart any sedation or morphine, which may have helped, kept her comfortable. Next slide, please. In summary, this was a 68-year-old lady with a sudden hypertensive bleed who underwent an emergency decompressive craniectomy. There was no improvement in her neurological status post-surgery. So the family opted for palliative care and wanted to take her home. Discussion one is, since this was such a sudden traumatic event and the whole thing played out within 2 weeks from her coming to hospital to her having a cardiac arrest, how could we help the family gain acceptance of the situation in such a short time? It was we found it very difficult. And the second thing is, when she was gasping on the ventilator, could we have persuaded the son? Was there anything else we could have said to the son to let us start morphine or a morphine infusion or something, or some sedatives to keep her comfortable? These were the two things that I could think of, sir. Thank you.
Dr. Nilima.
Yes, sir.
One of the best things that is happening in this country is that so many neurologists are taking an interest in palliative care, so that India has a neuropalliative care program, and that people like you are discussing issues like this. This is not happening in cardiology or in most other fields, but this is really something that gives us hope for the future. Thank you for your presentation. Gauraiya, do you want to start?
I actually lost connection for some time in between. So if you or Dr. Sunil want to go
do you
on.
want to?
Okay. So these are the patient is obviously suffering, and the daughter is unable to see the scene on ventilator.
Yes,
so this is something which we experience in our practice also. Not on ventilator, but the usual patients who have, some of the patients might have refractory symptoms. And then we might need the patient to put on some sedation. So the problem is that when we discuss with families, some of them they don't want, and there will be son, daughter, and many others are involved in decision making, and this is a complicated situation. So we have to call for a family conference, and from the we should talk from the patient perspective. So if we are in the position of the patient, what should we would have opted for? So in such a situation, after discussing with the family the pros and cons of not pros and cons, actually the patient is suffering, so we should be with the patient, and we should be an advocate for the patient. So we should tell them that okay, she's in maybe she's dying, but she should be in peace and dignity. So we have to do something for her. Otherwise, when you look back after some time, you will feel that my mother went with a lot of distress and pain, and she was breathless. So all those feelings will come in your mind. So that way, we should be able to talk to the patients, caregivers, to make them understand that treating the suffering is important, and you also need to understand that this one conversation with the family will not be enough. They will continue to talk to us, because there will be many people, even though we do a family conference, there will be many people coming behind them and talking to them. So at last they will reach a conclusion, but we should help them to reach at a conclusion that patient is suffering, and we should do something to reduce the suffering.
We did have multiple conversations, like every day the situation would be explained to them. The son seemed to be the one who was taking most of the decisions, like in the family, not the father, not the father. By father I mean the patient's husband. The son seemed to be the one who was taking most of the decisions in the family. I mean, he was the more how shall I put it, the one who was, talking more and wanted things to be done. And he was adamant that, he didn't want any medicines, but maybe communication from our side also saying, those words are important, the way we also talk to them, like saying, you want your mother to, be comfortable in your last, that may have helped, that those words could have helped maybe when we communicate with them. So I will remember those words.
Yeah, and even I think when the sons are adamant, there should be some reason behind that. We have to find out actually what is the reason. You are adamant, or you are saying that no need of medicine. Can you explain, or do you have some experience? We understand that you are concerned for your mother. You love her so much. So those are some empathetic statements that you can use, so that the son will understand that the person sitting in front of him is
also
a person who is, and maybe as you rightly did, every day we have to communicate with the family about the status of the patient. Otherwise, when we don't give proper information on a regular basis, then that would be also a problem.
Nilima, you had two questions. What was the first one?
So it was such a short time frame between the starting and from the time that she had the bleed to her passing away, just 2 weeks. So family found it very difficult to gain acceptance of that, especially since it was COVID and they hadn't seen their mother for so long with travel. So that was very difficult for them to accept it in that short time.
Yes, understandably, when it's a sudden loss.
So. Yes,
sudden loss, the sudden, as far as the woman is concerned, maybe we could even argue that this was the best way she could do. She dropped down one moment, became unconscious, possibly never suffered at all. Whereas when there is a sudden loss, the family finds it very difficult, and many of them could go into pathological grief or complicated grief, which is one of the problems. You are absolutely right. Here there were 2 weeks, 2 weeks of ventilation and several issues, etc. But maybe that those 2 weeks made it in the long term a bit easier for the family, the coping. Let me bring up another one. Nilima, as far as we know, when somebody starts that gasping kind of breathing, it tells us that the higher part of the brain has sort of shut down, and it is only medullary functions that remain. And therefore, it is highly unlikely that the woman was suffering when she is gasping. Now, you are the neurologist. I
Mm.
don't know. This is my assumption. Please correct me if I am wrong.
Sir, it's usually when they become acidotic. That's a kind of acidotic breathing. She had become anuric by then, and she had gone into an acidosis. So that was the kind of gasping ventilation.
No,
That
I'm not sure that
really
acidotic
was-
breathing is
Mm.
gasping breathing.
It
Acidosis
was,
results in very long, deep breaths and very, like large tidal volumes. Anyway, okay. Whether, I'm just saying that possibly it was a question of discomfort to the daughter, and maybe the patient would not have felt any discomfort anyway. But the question could be relevant in another situation. Within the limited time, let me bring up another issue to the larger group, not to Nilima. They stopped, they de-escalated treatment, did not resuscitate. Was that a legally okay thing to do, or was it illegal? Anybody who has not spoken so far in this group today, please give your comment. Was this legally permissible?
We have a comment from Dr. Sashidharan in the chat box. He says it's legally permitted.
Shashi, thank you. Dr. Nilima, I hope I didn't upset you with the question. My answer would be, it is not illegal. There is lack of legal clarity on the matter. I would say it is not illegal. I would agree with Shashi in that fashion to say that this was the humane thing to do. India does not have a law covering the subject. First statement, India has no law covering this subject. India has a law covering this subject when there is an organ transplantation, strangely, but not when there is no organ transplantation. Second statement, a Supreme Court judgment of 2018 is valid, in which case it is permissible to withdraw life support if you go through a series of processes which would take at least a month. Was not practical. In fact, to the best of our knowledge, nobody in India in the last 3 years has died going through that process. So, if that process is not done, would that make it illegal? As I said, there is no law, but legal opinion is that all that question arises only when there's a difference of opinion within the family. If the family is agreeable, Dr. Nilima's duty of care comes first, because no law demands that Dr. Nilima should do anything that is not benefiting the patient, that may actually be harming the patient by prolonging any possible suffering. So, if our duty of care is to mitigate suffering, this is not binding on us to prolong the suffering at all. And if the family members were in disagreement about some saying that no, we can't allow our mom to die, do please give more inotropic support or continue the ventilation, then it would have been different. In this case, it was not illegal. It was clearly the ethical thing to do. And the way the patient was treated, the way the conversations went on, this was near perfect, except for the slight difference of opinion that you have with the son about the sedation. But I personally think at that time, the patient would not have had any suffering. So maybe it all ended very well as things stand. If could anything, if I were the patient, would I have liked anything different? I don't know how many of you want to think in those lines of putting yourself in that place. Just want to tell you all, because I don't know who is going to be my doctor. I have written down my advance directives, a living will, which I have discussed with my wife and children, saying that at my age, unless, if there is the chances of me, my life being restored to a reasonable quality of life, no aggressive treatment should be inflicted on me. And I have written against artificial ventilation of the lungs or cardiopulmonary resuscitation in that event. Why am I telling you this? Not only for the selfish reason of you knowing this and helping me when my time comes, but also because with the current legal confusions, I think it must be something for all of us to do. But even more importantly, these are things that we need to discuss in our own families. Because it's not only about somebody else, we are also talking about our own elders in our own homes. And this is about everybody. But specifically, any questions about that legal position and end of life clarity? By the way, for the information of everybody, on our website in the resources page, there is a section on end of life and a copy of a format for advanced directives is given here, there, for anyone who is interested.
So in our hospital, what we do is they sign the legal guardian or the son or one of the relatives, they sign a do not resuscitate form where we've mentioned clearly what the complications are if we de-escalate treatment. And they sign that they're willing to accept this. That is as far as the DNR is concerned. And the second question that you asked, sir, what would if I was the patient, what I would have done? It just got me thinking, like if I was the patient, even if I wasn't in pain, I would not want my loved ones to be distressed at the sight of me on a ventilator. So that distress of the daughter was quite a sight to see. It's quite sad to see her upset. So maybe I would have wanted something to be started so that, you know, even her, she wouldn't feel upset seeing her mother's last moments on the ventilator.
Yes. Yes.
I mean, that's the way I would have looked at it. But everyone has a different way of looking at things. So
thank you, Dr. Nilima.
thank you, sir.
Yeah. Any other comment from anybody who has
Sir,
not
I
spoken
see
so
a
far?
comment in the chat box. DNR is permitted. Brain death should be established. So, Dr. Ashok,
if brain,
I'm not sure what does he want to express, but if he's here, can you come up?
Yes, what I was understanding that if there is brain death, then it is permissible to take the person out of the ventilator.
Oh, yes. Doctor, you are absolutely right. A brain dead patient is considered a dead individual. If brain death has been established, there is no reason to continue the artificial life support measures. Yeah. And very recently, it's only less than a month, actually they had put it up some time back, All India Institute of Medical Sciences, Delhi, had come out with some DNR recommendations, which in between they had withdrawn. They have brought it back. It's being published. And in another 4 days, ICMR is going to conduct a meeting about it, about just a sort of acceptance of the DNR guidelines. What that means is, that is not only covering brain death. If it's brain death, established brain death by the tests, then there's no controversy. The vast majority of people who are vegetative or have major brain damage may not be brain dead. Even in that situation, these are the criteria that we talked about. If treatment is futile, that's restoration of reservoir quality of life is not possible. DNAR is permitted, and withdrawal of life support is possible. Withholding of life support is possible. Dr. Nilima,
Yes, sir.
about that your comment about giving that sedation for easing the woman's suffering, totally granted. I mean, though I said something against it that maybe she wouldn't have suffered, doing that for the woman's sake, I totally agree. That would have been good, provided the son doesn't go away feeling that you gave some injections to kill her.
Yes.
So that's the balance to be very fine balance there.
Yes, sir.
Thank you, sir, and thank you,
There is
Dr.
a
Nilima.
question.
Right. Please go on, Dr. Sunil.
No, I see in chat there is one question, and we can end with this. Why she was not taken out of ventilator, as she was not for any further intervention?
Doctor, as I said earlier,
It's not
there
legal
is
to take them off, but I'm sorry, sir.
yeah. See, as I said earlier, there is lack of legal clarity. It is possible only if everybody is concerned, is on the same page, and the doctors are also agreeable. It is of no medical value, but we have to understand that the family's concurrence is very important. There is a saying, dead people do not go to court, living relatives go to court. We have to carry the family with us. And in the practical world, even if we know it is being futile, we will not escalate treatment, but we'll continue whatever we are doing till we achieve consensus. I don't think we have a choice as a practical measure.
Thank you, sir. It's over to Gauraiya.
Right. As we have already, we are at the, it's 8:31. So if we do not have any urgent questions, we can end this session. Thank you, Dr. Harimohan, Dr. Nilima, and Dr. Gitika. It was excellent case, and we had a very good discussion.
Thank you, everyone.